Ladies, I am so excited to say that tonight I am being joined by Dr. Sharon Malone. I'm sure many of you know her. She is a leading OBGYN. She is based in Washington, D.C. She wrote this best-selling book, Grown Woman Talk. It is an invaluable resource, a medical resource, a friend resource for women, for women's health. And I think that we are really in a time right now where this conversation is more urgent than ever. And so I am so pleased to have Dr. Malone here with us on behalf of Alloy, because Dr. Sharon Malone, not only being an amazing OBGYN and best-selling author, but she is the chief medical advisor for Alloy. And tonight, one of the things that we're going to be talking about is using estrogen. Not only is estrogen available for, via HRT and vaginal estrogen, but there are creams for your skin. Now, I have been using this cream for the last few months. I am 54 years of age and I really don't do anything, so I just want you to see how amazing this M4 Estriol cream is. And we're going to get into all of that. But I just want to start by saying hello, welcome, and congratulations on your best-selling book. Are you so thrilled to be a New York Times bestseller?
You know what? Not only am I thrilled, I'm surprised, because if you had told me 5 years ago that this is where I would end up, I was like, you're kidding me. You're kidding me. So you know what? So I'm very pleased. I'm very grateful that people have found things in my book that have resonated with them. And that makes me very happy.
Yeah. I mean, listen, the book is really great. I feel like what I loved about the book, and we were kind of talking about this earlier, and we'll get into it a little bit more, is sort of the discrepancy that there is in healthcare, not just for women, right? And I think, it's written in the foreword that it's like, women are routinely warned, lectured, and threatened about their health. They are often ignored, dismissed, and shamed, but they are rarely empowered. And I think that this book is a phenomenal resource to really helping women understand their health. As we get older, and this, we deal with so many confusing symptoms. Menopause brings its own host of really confusing things. I recently had vertigo on top of all my other menopausal symptoms, and you don't know whether you're coming or going, and you don't know if they're like things that are menopausal or if they're like real health issues, not to mention that women have higher, heart issues are the number one, right. What are they? The number one cause of death for women in old age. Is that right? Like, what is?
Not even in old age, Cait. I mean, that's, I think, the misconception about cardiovascular disease is that it only affects old people. It's like, no, we worry a lot, and we should, about breast cancer. But the reality is, for every decade of a woman's life after the age of 30, more women die of cardiovascular disease than die of breast cancer. And that is by a factor of anywhere from 2 to 7 times more women die of cardiovascular disease. And yet we don't think about cardiovascular disease. But there is a link. And that's what I really want women to understand, that none of these things happen in isolation. There's a link between that increased risk in cardiovascular disease and menopause.
It's really so insane. I'm so glad that there is now a tidal wave of women, smart doctors, yourself included, that are leading the charge to help not only empower us, but also get us the information. And we will get into that too, because Alloy, which is, I would like you to tell the audience a little bit about Alloy. I've used Alloy. Alloy was how I got my cream. So tell us a little bit about Alloy, and then let's talk about the M4 cream, because and I think I'm saying it wrong. It's the estradiol cream.
It's M4.
Which is, it is M4, right? I thought maybe it was MP4. I'm confusing myself. So tell us a little bit about Alloy.
All right, I'll tell you how I got started with Alloy, because, before joining Alloy, I had been in private practice for almost 30 years in Washington, D.C. area. And just as I was thinking about making a transition or trying, or just leaving because, you know, I was ready to do something else, Anne and Monica found me, and they came, these two brilliant young women. And I say young women because they were under 50 then. They've joined me in the over 50 crowd now. But they thought about, let's start a company. They've heard from so many women, and not only hearing it, but actually experiencing the lack of care and the lack of being able to find qualified doctors to treat menopause and menopausal symptoms. And they said, you know, hey, there's got to be a better way to do this. And perhaps if we use an online sort of telehealth company that focuses on menopause and perimenopausal women and making sure that they are connected with qualified menopause-trained doctors who can not only just discuss the symptoms, but prescribe, treat, and have that treatment showing up directly to their door. And that was the concept. So we really started this 4 years ago, and we were thinking about getting hormone replacement therapy to women who wanted it, needed it, and could not find a doctor who would prescribe for them. And once we sort of—
Which is so pervasive, by the way.
Once we opened that box, I mean, it really exploded because I think the experience of not being able to find a qualified doctor is more the rule than the exception. So we had an enormous opportunity, I would say, to use my expertise, and I've been treating menopause for over 30 years, and to figure out a way to make sure that we can do this responsibly, the way that we can do this based on science, not just, you don't have to take anyone's word for it or because someone believes or doesn't think. My job was to make sure that we sort of stayed really true to the science. And that is how we've approached hormone replacement therapy for women. And I think it's been a very successful venture because of that.
Yeah, I definitely feel like it shifted the conversation. I also feel like the Women's Health Initiative, which has played a huge role in my menopause journey because I am a breast cancer survivor, and the Women's Health Initiative, which was the original study, which was never fully completed and flawed in its own ways, really rang the alarm bells, right, very early on. And so any research was sort of halted, right? And we now have new studies. I mean, everybody's covered it. The Wall Street Journal, the New York Times, NAMS, you know, the swell events talk about it. You've talked about it in your book. But I think I think women are now starting to get over the fright and really search for answers. I mean, I used Alloy as a resource when I was really doing the deep dive on, like, can I, as a breast cancer survivor, you know, have HR, you know, use HRT. So I know that just getting information, like when I was in my vetting process of that, was really invaluable. And we'll talk about that in a little bit. I want to talk about the M4 cream because I don't think a lot of women know that you can use estrogen as a cream on your face to help you look your best as you get older. I want to read some of the stats around this cream because I do feel like a lot of people, like regular estrogen, have a lot of questions. What I think is, as a former journalist, what I find really great about this cream was that it was like a triple blind. So this was an independent expert dermatologist investigator did a double-blind 3-arm placebo-controlled study of the efficacy and safety of the M4 Estriol Face Cream. This is the face cream I've been using, you guys, for months now. After 12 weeks, the check-in baseline showed 88% improvement in skin elasticity, 70% improvement in hydration, 57% improvement in skin texture, 48% improvement in radius, and 68% improvement in overall skin health. Wow. That's incredible.
Wow. And let me just say, I'm going to break this down for people who really don't understand that the mechanics of the study and why we did it this way. When we say it's a double-blind study, what that means is the three things that we were testing, which was the estriol, the 0.3% estriol, the 0.01% estradiol, which is what is in typical vaginal estrogen, and a placebo, the double-blind aspect sort of takes out of bias, because the person who is evaluating the patients, the patients who are enrolled in the study, they don't know. All of the creams look the same. So they don't know whether or not the patient who they have to evaluate is on the estriol cream, the estradiol cream, or just a placebo, which is just the base that we use for the cream without the active ingredients. And the advantage of that is neither the patients nor the doctors know which one the patient's on. So that way, when you do the evaluations, you don't introduce bias of someone saying, oh, well, I think the estriol, we all can influence ourselves and make ourselves believe things that aren't true. Right. That's why we do the studies. And so that made it very clear that whatever we found at the end of 12 weeks was going to be based upon actual observations, not just someone's subjective opinion about whether or not their skin was better and the hydration was better. So that's the important thing about this. And, and one thing I want everyone to understand is using estriol in face cream is not new. We redid this study for a couple of reasons. One, to sort of verify the findings, because there have been studies that have been done on estriol cream before, but they were back in the 90s. And I think there was a review done maybe in 2013 or so that looked at all the studies. But it gets back to the Women's Health Initiative, because even though we had information about using estrogen cream topically on the face, once the Women's Health Initiative came out and said, sort of cemented that idea in women's minds falsely, that estrogen causes breast cancer, all of the conversation around estrogen went away. And a lot of the new research never really got finished after that. We were updating information. So yes, for that. But the real important piece of it that we wanted to make sure that all of our customers and patients understood is the safety aspect. Because many people are concerned. They're like, well, wait a minute. What if I'm using estrogen replacement? If I'm using estrogen already, what if I use vaginal estrogen? Is this going to be too much? And to answer that question, we not only looked at the qualities of the skin, but we also did blood tests to find out whether or not the women who were using the estriol and the estradiol, whether or not there was any increase in the estrogen levels in their blood. And it was not. So that's a very important point that I want people to understand, that using a topical estrogen, one, it's a small amount. Two, it's not systemically absorbed. So what you put on your face stays on your face. It doesn't travel far from there, much in the same way that vaginal estrogen stays in your vagina. It doesn't go. So for people who have contraindications to using estrogen, for people who are concerned because they've had breast cancer, one, we wanted to assure you that the safety element has been discussed, no systemic absorption, and no appreciable uptake in the bloodstream from people who use estradiol topical cream.
And that is so important. We did have one question. El Ginzi wanted to know, is this cream prescription? And it is, and you can get it on myalloy.com. That's how I got mine. I went right onto the site. I typed in my information. There is a doctor. Is this typically how it works? Like a doctor will connect with you, sort of ask you about your history, and sort of, it's kind of a one-on-one. It's almost like you're getting your own little private doctor's visit when you're on My Alloy. It's so easy. And I encourage everybody to really check out My Alloy. All women over 40, any woman that's in perimenopause, as you start your menopause journey, it's so important to get ahead of, the things that you're going to be dealing with. And I think if you have a partner, like My Alloy, that has amazing doctors that can really help just, guiding you, giving you information. It's a great resource. So myalloy.com is where I got this. It was a prescription. I had my conversation, and I think less than a week later I had it, which was great.
Yeah. And I think that, of all the things that we talk about in perimenopause and menopause, one of the things that we don't really appreciate, but you couldn't really prove it. And that is the fact that in our skin, we have estrogen receptors everywhere in our bodies, but they're particularly sensitive in our skin. And the same thing that's happening in our skin, that's why we get vaginal dryness, because, itchy vaginas, all the stuff on the outside on the vulva, that's just skin. So it is reacting the same way that what happens on your face. And what we find is that women in the first 5 years after menopause, they will lose up to 30% of their dermal collagen. Wow. And that is why there's more thinning of this skin. It's more fragile. We get more skin problems as we age, just because we're literally losing collagen. And so after those first 5 years, you lose 30% of your dermal collagen, and anywhere from about 2 to 2.5% will be lost every year thereafter. And every woman who's looked in the mirror understands that.
Yes, I understand that. I do feel like after 50, it just kind of dropped off a cliff with me. I'm going to sleep with, I'm layering, and I'm doing, I'm doing the things. It really is. It's amazing the difference you see when you turn 50. It really is. Dr. Malone, will you tell us a little bit, what is the difference between estrogen and estriol, just so people understand the clear difference between the two?
Well, estriol is what's in M4 cream. Estriol is a bioidentical estrogen, but it is the predominant estrogen that we produce during pregnancy. It's usually produced by the placenta. And for those who may have been pregnant, you understand that a lot of women will find that their skin gets better during pregnancy. Their hair thickens during pregnancy, and it's because you are flooded with estriol. So that's the bioidentical hormone.
Interesting.
It is a much weaker estrogen than estradiol. Estradiol is the bioidentical estrogen that we make during our normal menstrual cycles. As you ovulate, you make estradiol. That's why a lot of the hormone replacement products that we use and that we use at Alloy use estradiol, because it is bioidentical, which means that if you drew it on a chalkboard, it's exactly the same chemical structure and compound that your ovaries make naturally. So estradiol, more potent. Estriol is actually weaker. But again, we have more, since we're just using it in the skin, we're not trying to get it everywhere. We're just trying to get it where we need it, which is in the skin. And that's basically the difference between the two.
Yeah, and I do find it extremely fascinating because, someone mentioned in the chat, we spend so much money on creams and serums and the things that we hope will work, where if this is part of your body anyway, if estriol is part of your bio makeup, it's going to be more effective. And so you can really scale back on a lot of what you're using when you're using things that are potent, right?
Right.
Potent powerhouses.
And let me just say, and I'm not really going to go at anybody else's facial, cream regimens. You can spend as much as you like, but the reality is that where is the science? And the science is behind the estriol and the estradiol. We looked at both of those in the study with when we looked at M4, and they performed comparably. And that's why we chose to use the estriol cream, because there's really more data on the estriol cream historically that has been used on the face. And, and for something that should be very reassuring is that prior to the 1990s, estriol was included in face creams, over-the-counter face creams. And it was only until 1990 that they said, oh, maybe we should take that out. And they took it out of the products and they went away. But Helena Rubinstein, from the 40s, 50s, 60s, they were using estriol in their.
Oh my God, I never knew that. Yeah. That's crazy.
Yeah. And so now we've gone around the world and back again. And now we realize that, it does work. So the key to this too is that using the estriol cream as a base, you can still use, if you have other products that you like and they work for you, if you're using, tretinoin products, you can still use those, but you use this as a base and you will probably get better results because the combination of the two would be better than either alone.
Yeah. Shantae says, I'm on month 4 of my M4 and it really has seen the biggest change in the last 3 to 4 weeks. It really is so amazing. There was one question. There's a few questions. So one of the questions was, and I'm trying to find the person who said this. Oh, okay. Veronica wants to know, does Alloy prescribe estrogen, transdermal patches, and progesterone too? Absolutely. Dr. Malone, can you answer that question?
Yes. Because remember, that's how Alloy was really started. We came to this with trying to get menopausal hormone therapy and perimenopausal treatment to women who were symptomatic, who could not find doctors that would prescribe for them. So we have the full range. We have oral estradiol, we have oral progesterone, we have patches, we have spray. We are soon adding another form factor for our estradiol. So we want people to find whatever works for you, because some people like the patches, some people prefer the spray, some people prefer the pill. And we have basically the same, many of the same options that you would get as if you went to CVS. They're just generic products with the exception of our spray. So yes, we do hormone replacement or menopausal hormone therapy. And I think what differentiates us from just about any other, even a doctor's office out there, is that with your prescription, you get access to a menopause-trained doctor. You are able to text and ask questions back and forth with that doctor anytime for up to a year if you keep your prescription going.
Yeah, that is so amazing. Because one of the toughest things, and listen, I am I am in the menopause space. I'm in New York, and I found it extremely difficult to get information, especially because I am a cancer survivor, but I'm like now so far out. But even my female doctors, my endocrinologist, my primary doctor, we're all, and listen, I love my doctors, but there even within female doctors, there was a limited, amount of information, but also a nervousness about having that conversation. And so having a resource that can really help you and help you feel confident in whatever choice that you make there is really nothing more valuable in my opinion. When you have a doctor who doesn't know, or you have a doctor that's nervous to give you information, it really hampers the help that you can have. And it's made such a huge difference in my life. Magic wants to know, what are your thoughts on, and I'm going to mispronounce this because this is a science word, norepinephrine acetate and ethinyl estradiol.
Yes. And that is those are the estrogen. These are the non-bioidentical options for hormone replacement therapy.
Okay.
And here's the thing, or the ethinyl estradiol is generally used in birth control pills. So ethinyl estradiol is a synthetic. I only want to say synthetic because synthetic means it's man-made. They're all man-made. They don't exist. You're not pulling them up out of the roots in a tree or anything. What you are doing is just saying that these are typically non-bioidentical estrogens and progestins that are used in birth control pills. They're fine. There's nothing about that I would say, oh my God, that's synthetic or that's non-bioidentical. We've used them for years, for many, many years in birth control, and you can take birth control pills There's no problem with that. But we tend not to use those in menopausal hormone therapy. So after menopause, we don't use them. We use them more for women who are perimenopausal and still getting their periods.
So it's kind of like the leaning into it.
Exactly.
Like as you're kind of going into menopause, you're just...
Like say, for instance, if you were still menstruating and you're 44 years old, but you're having signs and symptoms of a lot of the things that we associate with menopause, and you need birth control or you need cycle control, then sometimes, yes, we will use a birth control option.
Oh, that's interesting.
That will take care of both. It will control heavy painful cycles and give you birth control. Obviously, after you've completed menopause, you no longer need birth control and you don't need estrogen at that level. So menopausal hormone therapy is far less, anywhere from a half to a quarter the dose that's in a normal birth control pill.
It's really interesting because I have so many friends that are in perimenopause who are like, what do I do now? Like, how can I... And it's such an interesting phase to me because it's like, yeah, it's like there's so many of these women are uncomfortable because they're having irregular periods. They're starting to have some symptoms. They don't know how to, navigate it. One of my questions to you is, if you could give one piece of advice to women that are in menopause, going into menopause, what would it be?
I would say make whatever decision that is right for you. When it comes to menopausal hormone therapy, many of us make decisions out of fear, not from a factual basis, and it's an emotional decision. And unfortunately, this causes so many women to suffer unnecessarily. And, and I frequently say menopause is mandatory, suffering is optional. And when you are suffering, just know that there are safe, effective treatments for menopausal symptoms. And, so I don't think any woman should feel less than or feel afraid or nervous about getting the care that they need to feel how they want to feel as they navigate this menopausal process. You don't get a bonus at the end for having had hot flashes for 10 years. There's no cherry on that sundae at the end. The reality is that the menopausal symptoms that you have are often indicative of other long-term health complications than you can have. Increased risk in diabetes, increased risk in cardiovascular disease, increased risk of osteoporosis, as well as all the other things that we talk about: vaginal dryness, painful sex, and again, general drying of the skin. All of that stuff comes together. So what I would say to women, that one piece of advice is that if you are suffering, you should get treatment. You should at least have the discussion, make the decision that's right for you, but before the age of 60 or within 10 years of your last menstrual period, the benefits far outweigh the risks. That's my message.
Yeah. And I know that that's such a big question. I will say to all the women that are watching, a lot of other questions are answered in Dr. Malone's book, Grown Woman Talk. And I think it's, one of the things, I know that we're kind of coming up on the end here. This book has been amazing. It has so much information about navigating all sorts of, issues, your heart, your health, cancer, weight, the menopause journey. One thing that I wanted to mention, because I was really sort of taken aback by it as I was reading your book, just sort of the discrepancy in care and access that women, minority women, Black women, Hispanic women, all women of color really face. I want to read some stats because I feel like this was so informative to me. Black women have twice the risk of Alzheimer's. 50% of Black adults afflicted with dementia have high blood pressure. 80% of women who are of African descent are twice as likely to have fibroids, which I had, and they were horrible. Life expectancy for Black women is 7 74 and a half years. Is that right? And white women are 79.2. So they're like 5 points
Right.
less than white women, 81% for Hispanic women. Black women have a higher percentage of hysterectomies. You know, we talk a lot, and in this book, it addresses a lot of equality for women and equity of care for women. And I want to know, as all women, especially in this moment, what can we be doing not only to raise the voice and to move the conversation forward with menopause, but to make sure that all women are included in that conversation and have access? What can we as women be doing to help all women in this?
Well, the first step is really awareness, because I think that the reason we're so far behind and we've made so little progress in addressing the issues with women's health generally, because let's be clear about this, all women have been underserved when it comes to the research dollars that have gone into women's health for conditions that either primarily or exclusively affect women. You know, we're getting maybe 11% of the budget of the NIH, $45 billion. We get about 4.6 billion of that 45 billion. Well, just take this and then think about where that is. That's all conditions that affect women. So what about fibroids? What about migraines? What about endometriosis? All the other things that women that need to be studied. Well, we're 51% of the population, and yet we get 11% of the NIH budget on conditions that affect women. So awareness is number one, because I think that when we address the health issues of all women, then we pay particular attention to the things and to the disparities that Black women and women of color experience, because you're never going to get to that answer about what to do about Black women until we know what the baseline is. And to the extent that we do know those numbers, that's why when I wrote the book, I really thought about it from this perspective. I said, you know, everybody knows that book, What to Expect When You're Expecting. Well, my book is What to Expect If You Expect to Live Beyond 40. So yes, there's perimenopause and menopause, but as you said, it's heart disease, it's diabetes, it's endometriosis and fibroids. All of these things that you should have at least a passing familiarity with, such that if they come up, you know what to do. And I think that the number one thing that we have to do, and I say there's big A advocacy and little a advocacy. And the big A advocacy is getting involved, knowing what these numbers are. So when we talk to our legislators, when we are looking at the budget, when we are looking at what's going on at FDA, we want to make sure that we as women as a whole are represented. And then once we as women are included in these studies, then we want to make sure that there is adequate representation and diversity within these studies, so we can start to answer some of these questions, these gnarly questions we have about why the health disparities are as wide as they are. Yeah. Because, you know, we spend a lot of time talking about maternal mortality, and we should, because that's the statistic that most women are aware of. Oh, it's 2 to 3 times for Black women than it is for white women. But the reality is, pick any condition, and it's 2 to 3 times for Black women. So we can't look at a woman's lifespan and just solely focus on her reproductive years. There is far more to our lives than when just the amount of time that we're going to be pregnant. What about all the rest of our lives? You know, the average woman will spend anywhere from 30 to 40% of their lives in their menopausal state.
Don't tell me that. I'm going to plug my ears now.
No, that's a good thing.
No, I know. It is. It's just a crazy, crazy that you'll spend a third of your life in menopause and we have no information on it, you know?
That's crazy to me.
Yeah.
So that's sort of my thing, is that when you say, what can we do? We can learn how to be better advocates for all women. And then within that category, we're going to make sure that each subdivision of women gets the care and the information that they need to be better advocates for themselves, the small a advocacy. So when you show up in a doctor's office or you go out there, you know exactly what kinds of questions to ask and how to not let someone tell you or direct you in something when you know you can know better.
Yeah. You recently you live in Washington, but you recently went in, was it in front of Congress? Was it the Women's Health Initiative? Can you talk a little bit about what that was and how more women can get involved in it?
Yes, there's legislation, through a group, Let's Talk Menopause, and the a lot of menopause advocacy groups. What we're trying to do is sort of mobilize such that we will get in front of, we have 2 bills now that were introduced, one in the Congress and one from Senate. And it's actually all about making sure that women get healthcare dollars and research dollars for the things that affect us. Because another little, I think the more we know, the more, the better we're able to advocate for ourselves. Because before 1993, women were not even routinely included in clinical trials. Now, how crazy is that? Most of the medications that women take have been tested on men and then just scaled down for size and weight on women. But we know that women's physiology is different. Our hormonal makeup is different. Medications don't work the same in women as they do in men. So we need dedicated research. That's the next piece of this whole movement that we're trying to do. We want to get information and we want women to be able to advocate because we deserve it.
I think it's amazing. I think it's amazing that we're at this place. And I just want to thank you, Dr. Sharon Malone, for joining us tonight with Alloy, from Alloy, Chief Medical Advisor from Alloy. And for all of those of you who have joined tonight, just a quick reset of the room, the M4 cream. Now I'm saying, am I saying it right? Estriol?
Estriol.
Estriol. M4 Estriol cream is amazing. I got it. I'm going to say this again. Ladies and gentlemen, I am 54 years of age. I don't do anything except for this. It is so good. It is so good. So
I use M4 and I've been using it for a year and I'm 65 years old and
you look phenomenal. It really is. It's crazy. You look so good. So this is the secret, guys. And you can get it at myalloy.com, where Dr. Malone is Chief Medical Advisor. You can get your HRT there. You can get information. You get access to a variety of amazing doctors who can help you through your menopause journey. And it really is a great telehealth company that is helping women, navigate menopause, perimenopause, and postmenopause. So, Dr. Malone, I want to thank you so much. Your book is really so incredible. A New York Times best-selling book, best-selling author right here, Chief Medical Advisor of Alloy, and a leading voice in the menopause movement. So I am just so grateful that you took the time tonight, late, we're all going to go to bed now, to spend with us. Thank you. Really, thank you so much. It has been a real honor to talk with you. Thank you, Dr. Sharon Malone.
You are so welcome. It was my pleasure.
And thank you to Alloy for allowing this to happen, because the more we can have these conversations and get the information we need, the better we are going to be as women. So good night, everybody. Thank you so much for joining us here on my TikTok with Dr. Sharon Malone. Grown Woman Talk. Get the book. It's amazing, guys. And your M4. That's really amazing. All right. Night, guys.